This recording is on the principles of chemotherapy. The last couple of slides deal with a few specific chemotherapeutic drugs, but most of the lecture will be looking at the general principles contained within chemotherapy. So just as a background, so you can see over here that cancer cells are really due to changes in the DNA. So what happens in the DNA of cancer cells is that oncogenes are activated, and the prefix onco means cancer, right? So oncogenes are cancer-causing genes, and we also have other genes called tumor suppressor genes. So as the name suggests, tumor suppressor genes stop cancers from developing, and oncogenes are actually a mutation of normal genes called proto-oncogenes. So proto-oncogenes are normal, whereas oncogenes are the ones that help to mutate the cell in order to increase the likelihood of cancer forming. And so what happens is that the DNA of cancer cells change so that these normal proto-oncogenes are converted into oncogenes, and then these tumor suppressor genes are inhibited. And so there's no break to actually stop cancer from developing. Now, just as a review, characteristics of neoplastic or cancer cells are that they keep on dividing, right? And the division of the cancer cells is continuous, persistent, and it's unregulated. So it doesn't know when to stop. So it just keeps on growing and growing and growing. Now, some cancer cells grow slowly, other cancer cells grow quickly. And we know this when we actually think about the frequency of tests like pap smears to actually see whether someone has cervical cancer, or even a colonoscopy to check for colon cancer. They don't happen every 3 months or 6 months or every year. They actually happen every 3 to 5 years, right? So you can see that the cancer cells grow slowly. The other thing with cancer cell is they can invade. So what happens is they can actually make its way into the space that should otherwise be occupied by normal tissue cells. And they can also spread from one organ to another. So a cancer which might start in the prostate gland can spread to, say, the bones, the femur, or to the lungs, or to the brain. And also the last property of cancer cells is that they don't die. They don't die as easily. So, for example, a normal red blood cell will live for 120 days, and a normal platelet will live for 5 to 7 days. But if they were cancers of those cells that produce red blood cells or platelets, they would actually last for a lot longer than the standard normal lifespan of the red blood cell and platelets. If you see over here, what we have here is we have the number of cancer cells on the y-axis, and we've got time. And you can see here that the time is unlabeled, so it's just increasing time. And so you can see here, if there's 1,000 cancer cells, it weighs about 1 microgram. 1,000,000, it weighs at 1 milligram, and 1 billion, it weighs 1 gram. Now, a 1 gram weight of cancer is the smallest detectable mass of cancer, and you can see that anything below 1 gram or anything below 1 billion is subclinical. So it has no obvious signs and symptoms, and it only starts becoming obvious in terms of early symptoms above this 1 gram, right? And this is where diagnosis happens. And you can see here that the difference between 1 gram and 1 kilo, where it actually becomes lethal, is the difference between 1 billion cells and 1 trillion cells. And you can see that once the early symptoms start appearing, then it doesn't actually take long for the symptoms to go from just a few minor symptoms to actually the symptoms affecting the person's well-being or bodily functions, as well as affecting various different systems in the body. This is just a picture of the cell cycle. So what we have over here is we have the cell cycle, where you have, first of all, G1, synthesis of components needed for DNA synthesis. And then the S phase is where you have the DNA being synthesized itself. G2 is when you've got other components needed for mitosis. So this would be the formation of more cytoplasm, more organelles, more phospholipids, and all that kind of stuff in order for cell division to occur. And then you've got mitosis. And you can see that this is part of the cell cycle over here. Now, this G0 phase here is when the cell is resting. So when the cell is resting, it means that it's just going about its business, living as a cell, but it's not actually actively dividing, right? So the rule of thumb is that tissues that are mainly in the G0 phase, they're not actually actively dividing, right? Whereas tissues that are actually in the in any of this active cell cycle phase, the active stage, they actually are good targets for chemotherapeutic drugs, right? So you can see over here you've got low growth fraction and you've got high growth fraction. So low growth fraction are tissues that are mostly in the G0 phase. So in terms of normal tissues, that would be your bone tissue, the muscle, right? Cells that don't actually really grow as an adult. And in terms of cancer, types of cancers that are in the low growth fraction type, they are solid tumors. So solid tumors in the breast, lung, prostate, colon, rectum. Now, cells that are in the G0 phase are not very responsive to chemotherapeutic or cytotoxic drugs, right? Because most chemotherapeutic drugs at this given stage are cytotoxic. And cyto means that it's poisonous. Cytotoxic means that it's poisonous to cells. And so these tumors, the solid tumors, and a lot of the normal tissues are actually in the low growth fraction stage. Tissues that have high growth fraction include fast-growing cells, so your hair, the epithelium in your digestive tract, so in your mouth, in your esophagus, in your stomach, and throughout your digestive tract. Bone tissue, blood cells like red blood cells and white blood cells and platelets are also always continually dividing because, as I said, platelets last for 5 to 7 days, red blood cells last for 120 days, and white blood cells have a variable lifespan depending on whether there's any invasive pathogens in the system. And so those are normal tissue that are fast growing. In terms of the types of cancer that have a high growth fraction are disseminated cancer. So this would be lymphocytic cancers, Hodgkin's disease, leukemia, and certain types of testicular cancer. And because these cancers are actually always rapidly dividing, what happens is that it's actually a good type of cancer that can respond to cytotoxic drugs. And we'll look at that in a bit later on. So just some basic principles of cancer chemotherapy. First of all, I wanted to look at treatment modalities. So there's surgery and radiation. And usually surgery and radiation are done back to back, surgery being the first step, and then radiation being the second. And these are usually used to treat solid cancers. So the solid cancers are your breast cancer and so on that are listed in the previous slide. And then you've got drug therapy or chemotherapy. And these are used for disseminated cancers that are widespread, like the leukemias, the lymphomas, and metastases. Now, the types of chemotherapeutic drugs that are available are listed here. So cytotoxic drugs are the ones that are used often. And again, cytotoxic means cyto is cell, toxic means it's poisonous. And so they basically kill fast-growing cells. And then some cancers respond well to hormones or hormone antagonists. Some respond to biologic response modifiers, and some cancer drugs, some cancers, very few of them at the moment, respond to drugs that are specifically designed to target that particular cancer. But again, those are very few and far in between. Now, benefits of chemotherapy, obviously, in most cases, you would want and hope for a cure. In other cases, it's for palliation, so to have a better quality of life if it doesn't offer a complete cure, and also to prolong a useful life, to extend the life of a person living with cancer. Now, in all cases, what happens is the benefits of treatment must outweigh the risk, right? Because chemotherapy does have a very great risk, and so the patient has to feel and has to agree and has to know that the chemotherapy therapy has some sort of benefit that outweighs the risk of it. So again, this is basically the same information as in the previous slide in the first part. So what you have is you have treatment of cancer cells here split into solid tumors and disseminated tumors. And in solid tumors, we have low growth fraction, so not actively dividing. And then what happens in solid tumors is if you have a tumor that size, what happens is as it gets to the core, there's less blood vessels there. And so most chemotherapeutic drugs have to somehow enter into the systemic circulation. And so if you have less blood vessels, so it means there's less blood supply. And so it means that drugs don't enter into the core as easily. And if they can't enter into the core of the solid tumor as easy, they can't actually wipe it out, right? So the treatment options for solid tumors is usually surgery followed by radiation, and that basically cuts out the bulk of it. So I'm going to remove this this tumor. Say I'm going to cut out that, and then whatever remaining part will actually leave G0 and enter into that cell cycle, and then you can actually hit it with chemotherapy, right? Disseminated cancers are spread all around, and they have a higher growth fraction. So again, if you look at the cell cycle, they're always somewhere. There's more cells that are in that growth, in that active cell cycle stages rather than in the G0 stage. And so that's where the chemotherapy actually comes in, to actually kill those actively dividing cells, or to use immunotherapy or hormonal therapy. Some of the obstacles to successful chemotherapy is that, first of all, they're toxic to normal cells that are actively dividing. Or you can say cells that have a high growth fraction, and we'll talk about that in the next slide. The other thing is that it's impossible to produce a 100% cell kill, because what happens is that at any given dose, drugs kill a constant percentage of the malignant cells, regardless of how many cells are present. So say, for example, you start off with, 20 billion cells. And each round of chemotherapy is going to kill 90%, right? So if we kill 90% of the cells, then it means that after the first round of chemotherapy, you only have 10% left. So you have 2 billion cells left. And then after the second round, you have 90% left. So you have 200 million. and then after the next round you have 20 million, and then the next round you have 2 million. And so you see that at any given point you still have 10% left, right? So you can't produce 100% cell kill, right? So that's one thing. Now, from the previous slide, we see that the smallest detectable mass of cell is 1 gram, which equals to 1 billion cells. And below this, it's subclinical, right? The symptoms are subclinical. And so what happens is that the symptoms stop before 100% elimination of cancer cells, because once it goes below this 1 billion cell number, it becomes subclinical, and you don't really know whether the patient still has cancer cells floating around in their body. The third thing is that, so that's that, and the third thing is that the patient does not mount an immune response. So there's nothing in the patient to actually help the process along. And the last point has to do with toxicity to normal cells too, right? Drug dose must remain constant throughout the regime, even when the patient is getting, say, weaker and sicker because of the effects of the actual chemotherapy itself, right? So we're assuming that the patient is as healthy after the 5th round of chemotherapy as they were before they even started, but in most cases we know that that's not the case. Because what happens is the patient may have lost weight, may not be able to eat, may be throwing up, or may be, immunosuppressed or have undergone myelosuppression, and we'll cover all that next. And so the host tolerance is not the same as the treatment progresses. So over here, what we have here is we have obstacles to successful chemotherapy. So the first one is that if it goes below 1 gram or 1 billion cells, it becomes subclinical. So we don't really know whether the patient is symptom-free because all the cancer cells are killed, or whether the patient is symptom-free because there's less than 1 billion cancer cells. Another obstacle happens is to do with solid tumors that don't respond poorly to chemotherapeutic drugs, and again, because the core of it, the middle of the solid drug, is less vascularized, so the cancer drug can't actually get into the core. The third one is that drug resistance develops over time to cancer cells. And so what happens is that if you see, if this is a cancer cell, we talked before about this P-glycoprotein transporter system, and what this P-glycoprotein does is it basically kicks things out, kicks the drugs out. And so you can imagine if you've got a chemo drug entering into the cell, what happens is the P-glycoprotein will actually kick the chemo drug out. And so what happens is the cancer cell doesn't have the chemo drug entering into it, so can't be killed, right? So this is a potential for therapeutic failure. Obviously, if the chemotherapeutic drug doesn't stay into the cell, it can't actually do its job. The fourth obstacle is that not all tumor cells are the same, and so some tumor cells may respond better to chemotherapy than others. So if you say you have 100 tumor cells, maybe 85% will respond well and be killed, right? And the other 15% might develop some sort of resistance and hang around, right? And that 15% might actually bring it down to subclinical levels, and it's not detectable, all right? Other times there's limited access to tumor cells, and so, for example, if a tumor is hard to reach, say in the brain or in some other area of the body, the drug may not be able to actually reach the site of the cancer cell, and so it might actually not be able to work. Some of the major toxicities of cancer chemotherapy are listed over here. So these are all, the first two categories are basically fast-growing cells. So they have high growth fraction. So one of the areas of the body that has a high growth fraction is in the bone marrow, right? And so cancer chemotherapy suppresses the development and division of bone marrow cells, and this is called myelosuppression. And so what happens is neutrophils numbers drop. You have neutropenia, risk of frequent and severe infection, right? You have thrombocytopenia, where you have a reduction of platelets, and that increases the risk of bleeding. And you can see over here, there are certain drugs that actually help to treat these various myelosuppression, types of myelosuppression. And then the third type of myelosuppression is a reduction in red blood cells, which leads to anemia, right? And if a person is anemic, they don't have enough red blood cells to actually deliver oxygen, and so that can be treated with a drug. And so if you look at the list here, you can see that neutropenia is treated by these three drugs, thrombocytopenia is treated by this drug, and anemia is treated by this drug, which is the hormone that's responsible for regulating red blood cell production. So that's bone marrow suppression. The other thing is that chemotherapy also reduces the rate of division of epithelial cells within the digestive tract, and so that might lead to nausea and vomiting. And again, this can be treated with antiemetics, because the logic behind that is that if you actually stop a person from feeling nauseous and stop a person from vomiting, they're actually more likely to eat because they don't feel so sick. And if they're more likely to eat, then they're less likely to lose weight, right? And again, weight loss is one of the big things with people living with cancer, because then it reduces their ability to actually fight, and it reduces their to fight the cancer, and it reduces just their overall stamina. Sometimes you have ulcers of the mouth, right? Inflammation of the oral mucosa. You have ulcers forming in the mouth, ulcers forming in the stomach, and that also just leads to the really not wanting to eat, right? Because who wants to eat when you've got a few ulcers in the mouth, and then when it gets down to the stomach, it actually leads to dyspepsia, feeling of unease in the stomach, and all that kind of stuff. And also diarrhea might be a side effect, and that's treated with loperamide or Imodium. And again, so what you see over here is you've got a chemotherapy that actually has widespread effect on other cells, other normal cells in the body, but thankfully there are drugs to actually treat most of these adverse effects that are common with most cancer chemotherapy. Other toxicity is local burning from the site of the IV. Carcinogenesis, it's kind of ironic that some drugs that are used to treat cancers actually cause other cancers further down the road. Alopecia, hair loss, again, hair is a fast-growing cell, and so hair loss is common. And then irreversible male sterility, because sperm in men is made every day, right? And so that's also a fast-growing cell, and so the cancer chemotherapy can actually adversely affect those cells that are responsible for production of sperm. And so one of the things to actually overcome this is to actually bank sperm before chemotherapy is started. And then there's other unique toxicities that are associated with various drugs. So you've got some denorubicin that can cause injury to the heart, cisplatin can injure the kidneys, and vincristine can injure peripheral nerves. And we'll talk more about that in a little bit as we go along. So, having gone through the adverse effects associated with chemotherapy, how do we actually, and the obstacles associated with chemotherapy, how do we actually develop a strategy to maximize the beneficial effects from chemotherapy? So one of the strategies is intermittent chemotherapy. So intermittent chemotherapy means that you don't give it all the time, you don't give it consistently, you give it at certain times, and there are times where there's no chemotherapy being given, right? Because one of the main obstacles is toxicity to normal cells. And so what we do here is you look over here, you've got normal cells in the solid green line, you've got cancer cells in the red dotted line. And so these arrows indicate when the chemotherapy is given. All right, so we start right at the start on the left hand side. We'll do this. So we've got X number of cells over here, right? First dose of chemotherapy is given, kills off normal cells as well as kills off cancer cells, and then hopefully in that space where there's no chemotherapy, the normal cells, the theory is that the normal cells recover to normal levels, while the cancer cells take a little bit longer to get up to the same level. So you see, they actually recover, but they don't recover as much. They recover at a lower level. And then the second dose is given, kills normal cells, kills cancer cells. Again, theory is that the normal cells go back up to scratch. Cancer cells return, but not to the same level. Returns to a lower level. And then the third dose, again, toxic to normal cells, toxic to cancer cells. Cancer cells don't recover as well as normal cells. And then the fourth, and then the fifth, and all that kind of stuff, right? And then you see the hope is that over time, with this intermittent strategy, that the cancer cells drop to virtually nothing, right? While the normal cells are actually to recover at least some, if not all, of their normal function. All right, so that's one strategy, intermittent chemotherapy. The other strategy is to deliver the drug into a specific location where it doesn't necessarily hit the systemic circulation first. So if you know that the cancer is located or isolated within a certain region, you can give specific intra-arterial administration so that it hits that local region. Or if it's in the brain, then it's given intrathecally so that it hits the circulation within the CNS sooner than it hits the systemic circulation. And also that means that, first of all, if it's regional drug delivery, then it's more directed at a specific location, and overall the dose of the drug can be decreased, right? Because you would assume that more of that drug will actually hit that specific location. And so what happens is there's less drug hitting the systemic circulation, and so the theory is that the adverse effects also drop. Another group of strategies for achieving maximum benefits center around combination chemotherapy, right? With combination chemotherapy, you've got two or more drugs given at the same time. So this combination chemotherapy is, as it says here, generally more effective because it reduces drug resistance, because it's given and it attacks the cancer cells via two different pathways. So it increases cancer kill rate, and it also reduces injury to normal cells. So you have less adverse effects, and you have increased benefits, right? So this is what you want, all right? When we choose a combination chemotherapy, what we need to do is we need to actually make sure that the different drugs for the combination chemotherapy have different mechanisms of actions, right? So you want this cancer to be killed by various different ways. You also want them to actually have minimal overlapping toxicity. So basically, if one causes myelosuppression, you want the other one not to cause myelosuppression. You want the other one to cause something else, some other thing, right? And also the third rule of thumb with combination chemotherapy is each drug has to be good when used alone, right? So you don't want two drugs that are not very effective used together. You want two drugs that are effective, and you want to combine them. So an example of that is actually listed below. So you've got these two drugs, cyclophosphamide, and you've got vincristine, right? So they've got good therapeutic effects when used by itself. Cyclophosphamide lowers neutrophil count, but has no effect on toxicity, whereas vincristine has no effect on the neutrophils, but causes neurotoxicity. And so when you combine cyclophosphamide with vincristine, you can see the anti-cancer effect is additive, right? So you've got four pluses, and it somewhat lowers neutrophil counts and somewhat neurotoxic, right? So you don't want to combine, say you don't want another drug other than cyclophosphamide that also has the same effect, that is also reduces neutrophils and has no effect on neurotoxicity, because if you combine it with drug X, what happens is anti-cancer effects good, but neutropenia will increase, right? And it'll have no effect on the nerves, right? So you want to actually spread out their toxicity, and you want them to actually be effective via different mechanisms and be effective when used alone. Dosing schedule need to be coordinated. So what we have here is we have some drugs that are cell cycles phase specific. So for example, you've got vinblastine and vincristine, which are only effective in the M phase. So what happens is when vincristine and vinblastine is given, it kills all cells in the M phase, but cells that are in the G1, S, and G2 phase are left unaffected. And so in terms of this, administration regimen is either for a prolonged infusion or multiple small doses at short intervals. And the logic behind the second strategy is this. So you hit it the first time, it kills, say, the 10% of cells that are in mitosis. And then you wait, and when you wait, what happens is the cells that are in the G1 move on to the S phase, cells that are S phase move to the G2, cells that are G2 move to the M phase. And then you hit it the second time, you might get another 10%, right? Because of these cells that were in the G2 that have moved to the M phase. And then you wait a while, and then what happens is the cells that are in the S phase then have moved to the G2 phase and now in the M phase. Then you hit them with the third dose, and that will kill those cells that were originally in the S phase and are now in the M phase. And then maybe the fourth time it will hit the cells that were originally in the G1 phase that have moved to the S and the G2 and are now in the M phase. Right? So again, multiple small doses at short intervals so that those cells move along to the phase where the drug is effective. Other drugs are considered non-phase specific drugs. And so what happens is, again, they are more toxic to proliferating cells than the G0 cells. So these G0 cells are really unaffected by either type of these drugs, but what happens in the cell cycle non-phase specific drugs is that it hits the cells that are anywhere in this actively dividing phase. And so for this, the chemotherapy can be administered as a single bolus dose because it just kills all the cells that are in the cell cycle. We're going to finish by looking at a few different drugs used for chemotherapy. So the first one is drugs that are cell cycle phase non-specific, right? So they hit at all these different actively dividing cells, and so can be administered in a single dose, toxic to cells both normal and cancerous, with a high growth fraction, and can develop resistance, right? So really, if you look at this, alkylating agents and platinum compounds, what happens is they produce these cross links or these intercalation. So you see over here, this is an example of an intercalated molecule. So this is DNA, right? So it's double-stranded. And what happens with these drugs is they actually form a much stronger bond between the two strands of the DNA, right? The two strands of the DNA. Now the problem isn't when the DNA is doing nothing. The problem is when the DNA is undergoing replication or is undergoing the transcription and translation process in order to make proteins, right? So in each of this case, you can see that the DNA, the double-stranded DNA, need to be separated in order for replication and translation and transcription to happen. But if you've got intercalating molecules actually sticking those two strands of the DNA together, they can't actually be separated, and so no replication takes place and no translation and transcription takes place, right? And so that that's what happens, and then it basically just stops the cell cycle in its tracks. So both the alkylating agents and the platinum compound, cisplatin, carboplatin, oxaliplatin, does this. Cisplatin especially is highly metatogenic, and also this platinum compounds are also known to be toxic to kidneys. So one of the strategies to actually overcome the renal toxicity is to actually make the encourage the patients to drink a lot and to actually give the patient diuretic, and so they basically urinate a lot, and then hopefully this will actually allow the drug to be flushed out of the system quickly instead of staying within the urinary system, the renal system, and actually causing toxicity there. Last slide, another some anti-cancer drugs that are cell specific. And so what you have over here is you have methotrexate, which is considered an anti-metabolite, and so methotrexate hits and affects cells that are in the S phase. Mitotic inhibitors affect cells that are in the M phase. And then you've got anti-tumor antibiotics that basically just injure cells. We don't need to know exactly why. And these anti-tumor antibiotics are always given IV because they're not absorbed well within the GI phase. So that's it for this lecture. All right.